Thank you. My name is Lisa Shook. I am a psychiatrist at Prairie St. John's Hospital in Fargo, where I do inpatient work. I am also the clerkship director for our UND psychiatry clerkship for our medical students and the associate program director for our residency program here in Fargo. I have some experience with ketamine. I've done quite a bit of training with it and had piloted and written a protocol for a ketamine treatment service when I was employed at Sanford previously, and have treated patients with ketamine through that service, and have experience with other neuromodulation, including ECT and TMS. So for today, we will focus on understanding ketamine's proposed mechanism in treating psychiatric illness, identifying the evidence-based applications of ketamine through use in psychiatric illness, and then look at some of the potential drawbacks to ketamine therapy. To start a conversation about ketamine in psychiatry, we really need to talk about the scope of the problem for treatment-resistant psychiatric illness. Our best is not good enough when it comes to treating our patients, particularly with mood disorders. We'll be talking a lot about depression, a little bit about bipolar disorder, but there is a lot of treatment resistance that occurs with our patients. And our treatment goal for depression is remission. And treatment-resistant depression is common and it is debilitating. When a person is started on an antidepressant, only about 1/3 are going to meet that goal of remission. Another 2/3 are going to have some response or have no response to that. And if you switch those that didn't have remission to a second antidepressant, again, only about 1/3 are going to remit, 1/3 will respond, and another third will not have a response. After 2 medication trials, about 20% of patients with MDD have no response to an antidepressant. And after 2 failed medication trials, the likelihood of reaching remission with another antidepressant, either switching to a different antidepressant or augmenting with something from another class, that's going to be around 10%. So there is a significant number of our patients who are going to end up in a cycle of trying medications, repeating some of the same things over and over again, and not getting good results. This was from a study on treatment-resistant depression and the number of antidepressant trials an average patient with treatment-resistant depression has undergone. So as you can see, many of our depressed patients are on the lines of 7, 8, 9, 10 antidepressant trials. And we know that once they've failed that second trial, all of this is really not going to be all that helpful for a patient. And when we have all these medication trials, it's going to take 4 to 6 weeks to even know if a medication is going to have its full benefit. When depression is untreated and suboptimally treated, it becomes harder to treat over time. And the risk of a future depressive episode increases when a person has recurrent episodes. So treating people to remission and keeping them there is incredibly important. Our patients do not adhere to medications that they don't feel are beneficial. If they feel like something's not working, it's having side effects, the treatment regimen, the number of times a day, the amount of medication that they're taking is complicated, they're much less likely to take the medications that they are prescribed with good adherence. Looking at bipolar depression, this tends to be, the depressive part of bipolar disorder tends to be the most debilitating and difficult to treat part of the illness. Mania is exciting. It gets people admitted to the hospital, but we have pretty good ways of treating mania. Most of our bipolar patients are going to be debilitated by very difficult to treat depression that lasts for a long time and really causes the amount of disability and quality of life decrease that we see. Folks with bipolar depression respond poorly to antidepressants. And we know that if we are treating patients with just an antidepressant with bipolar disorder, our biggest risk is that they're not going to get any benefit from it, but there's also some risk of destabilizing a patient's mood and causing some mixed states that can be quite dangerous for a person. Polypharmacy is very common in bipolar depression. On average, a person with bipolar disorder is taking 4 medications, and many of those are going to be targeted towards that depression. Just touching base with some other psychiatric illnesses, PTSD, it can be very chronic, and evidence-based therapies often require to have a requisite amount of distress tolerance to be able to go through the exposure protocols that are necessary for evidence-based PTSD therapy. And there are a lot of folks that get referred to trauma therapy who end up decompensating pretty spectacularly because they don't have the emotional regulation needed to be able to re-expose themselves to those traumatic events and do so in a way that feels safe. For schizophrenia, about 1/3 of our patients with treatment-resistant schizophrenia continue to be on clozapine, and they will have positive symptoms despite being on our gold standard treatment for treatment-resistant schizophrenia. And then we look at the negative symptoms with all of our patients who have schizophrenia. They tend to respond quite poorly to any of the treatments that we have tried. Anxiety disorders, they tend to wax and wane in severity over time. And although medications can be very helpful, therapy is extremely helpful in managing symptoms, it is something that tends to be a lot longer term than some of our more episodic illnesses. So we need better treatment, and the goal is to get more people better and to get them better faster. Neuromodulation, ECT, and TMS have traditionally been where we have been going for treatment-resistant depression and some other psychiatric illnesses. And the goal with these neuromodulations, so ECT is electroconvulsive therapy. That's where we stimulate a medically induced seizure in a patient while they're under general anesthesia. And TMS is transcranial magnetic stimulation. That's where we use a magnetic pulse that's placed over portions of the person's cortex to stimulate that part of the brain to respond. Those work because they induce rapid neuroplastic changes, and that leads to structural and functional alterations in the neurons. So we're trying to facilitate adaptive neuroplastic changes. So for example, we know that in patients who have had ECT, they tend to have increased hippocampal volumes. People who have cognitive dysfunctions as part of their severe depression, those pseudodementias, they actually tend to get better from a cognitive standpoint when their depression is treated through ECT, even though there are some short-term memory side effects associated with that treatment. So I think of neuromodulation as kind of going backwards from medication. When we give medication, we are trying to alter the way that the chemicals are released from the neuron and then stimulate other neurons downstream, so on and so forth. Whereas with our neuromodulation techniques, we are trying to get the neurons to fire very rapidly and then change the way that neurochemicals are being utilized by the brain in very large quantities in a short amount of time. ECT is our best treatment for depression, and even though it's really effective for MDD, it does have limited access depending on location. I think outside of Fargo, I think there's some ECT in Minot, maybe some in Grand Forks. I haven't heard recently. But beyond that, for our region, we'd be looking at going all the way to St. Cloud, to the east of us in Fargo, down to Sioux Falls south, and then somewhere out on the West Coast for folks to get ECT. ECT does have a lot of stigma associated with it, and it's not always an easy treatment to undergo. So patients, a lot of them have the preference to not do that. We do have to use general anesthesia, so there are some risks associated with that, and it can be disruptive to daily function during the treatment course. A person is coming in 3 times a week, typically for an induction. They're undergoing general anesthesia. They're recovering from that. People have to take time off of work. They have to have family there to drive them after the procedure and stay with them. So it can cause a lot of disruption in a person's life. TMS, on the other hand, has more patient acceptability. You don't have to undergo general anesthesia. You sit in a chair for anywhere from 3 to 18 minutes, depending on the protocol that you're using. The magnet pulses above your part of the brain that you're targeting, and then you go on about your day. So there's no medications. You can drive yourself. There's no cognitive side effects that come from it. There's very few physical side effects that come from TMS. But the concern with TMS is that a lot of our protocols that are approved by the FDA and are therefore reimbursable by insurances, you need to do repetitive treatments 5 days a week over the course of 4 to 6 weeks. So again, TMS is not widely available throughout our part of the region. There are difficulties with accessibility and time constraints, having to take off work when people are traveling long distances to get the treatment. And then if you try to compress the treatment, and there is some evidence to do that and do the treatments in shorter time frames, patients end up paying out of pocket for that. So ketamine is our chemical that will rapidly induce neuroplastic changes. It's an NMDA receptor antagonist, and it will inhibit inhibitory neurons to increase synaptic signaling between neurons. I think this picture demonstrates really beautifully the rapid proliferation that you will see in cells exposed to ketamine. So I believe these are neurons from a rat brain that were exposed to ketamine in petri dishes. The top is before the exposure to ketamine. The second is sometime, I think, somewhere around 40 minutes after being exposed to ketamine. You can see the dendritic spikes that have formed on that neuron. So it very rapidly increases neuronal growth and neuroplasticity. So kind of that in between of medications and neuromodulation using electrical stimulation, where we're both trying to stimulate the connectivity and the chemical response of our neurons. All right. So the initial randomized control trials on ketamine came about in the early 2000s, where sub-anesthetic infusions of ketamine were given over a single 40-minute infusion. And what we saw is a very rapid resolution of depressive symptoms and suicidality. So within hours of receiving this infusion, people were feeling miraculously better. And that's how people would describe it. It was miraculous. I haven't felt this good ever or for so many years. And the trouble is that that effect tends to be short-lived. Many patients will maintain a response for about 7 days. And then over time, that effect quickly drops off, and people are oftentimes back to where they were before they got the infusion. And these studies were repeated, and in a meta-analysis of 9 such randomized controlled trials, we're seeing similar results that an infusion over 40 minutes can really provide significant benefits for depression, but those results are not lasting. In 2016, randomized controlled trial on repeated dosing, 2 to 3 days per week over the course of 4 to 6 weeks was studied and published. And this was found to extend the effect out to about 15 days. So similar to what we might be doing with ECT, where we're treating a person several times a week and then trying to taper off, the thought was, well, if we repeat these infusions over a couple of weeks, can we get a person's effect to stay at longer? And it did seem to be helpful for that. Again, 15 days is not a substantiated and long-term remission of a person's depression. So right now, the protocols for ketamine infusions are mostly based on trying to determine the long-term risks and benefits of maintenance treatment. Can we find a protocol where a person gets these infusions to get themselves to a place of remission? And then for those people who struggle to maintain a remission after they have reached that state, can we give these infusions every 2 weeks, every 4 weeks, so on and so forth, in order to help them maintain their remission? S-ketamine, also known by the trade name Spravato, was approved by the FDA in 2019 for treatment-resistant depression in adults. It is the S enantiomer of racemic ketamine. So when a person is getting a ketamine infusion in the clinic, they are getting a mix of S and R enantiomers, and this isolates this just down to the one part of the chemical mixture, on the idea that there's a 3 to 4 high times affinity for NDMA receptors in S-ketamine versus the R enantiomer. And again, randomized controlled trials were showing rapid reduction in depression rating scales versus placebo, and both treatment groups experienced rapid reduction in their severity of suicidality score. So that's where S-ketamine has really come to shine, is in rapidly reducing both both major depression symptoms, but also reducing a person's imminent suicide risk. A 2021 meta-analysis of 10 studies in S-ketamine showed that there were mixed results on the difference between S-ketamine plus an antidepressant versus S-ketamine versus a placebo on depression symptoms. So we really don't know if it is necessary or helpful for a person to be on an antidepressant while they are doing S-ketamine. It does seem that when there is an active antidepressant given along with the S-ketamine, that there does seem to be some delay to relapse in that case. And like all things that come about and seem to be miraculous, we have to ask ourselves, well, is this really too good to be true? And in our desperation to get treatment to people, some of these things have been coming out a little bit later and studied later on in terms of trying to find why ketamine works so much and why people feel so much better. In 2018, there was a study that combined ketamine with naltrexone versus ketamine without naltrexone versus placebo to study the antidepressant effect. And it was interesting because that naltrexone did appear to interfere with ketamine's antidepressant effect. So that raised a lot of alarms about, is the antidepressant effect of ketamine due to opioid receptor stimulation? And are we going to be precipitating addiction and abuse? Ketamine is certainly an addictive and abusable substance. On the other hand, those effects could have been from the fact that some of these mute opioid receptor blockades attenuated some of the downstream mediators of the ketamine target. So it wasn't necessarily that it was the blocking of the opioid receptors themselves that caused a person not to respond. It was the downstream effects of that blockade that interfered with other mechanisms of ketamine. So that raised some suspicions. A 2023 Stanford study took 40 participants with moderate to severe depression who were undergoing general anesthesia for routine surgery. And they gave these ketamine infusions under their surgical procedures in order to blind the dissociative effect. It is really hard to get randomized and placebo-controlled trials for ketamine because that dissociative effect is really hard to replicate in placebo. They've used diazepam and other things to try and get that, but there's something that appears to be pretty distinct about ketamine that makes it hard to blind it. So they were giving these infusions while the person was under general anesthesia for routine surgeries. And after 2 weeks, the participants were told what group they had been assigned to. What they found was that both groups had had significant improvement in symptoms equal to the effects in other ketamine studies, and that most patients were unable to correctly guess their intervention. Now, you might say, is there something about the anesthetics that was used for the procedure, things like that confounded this? There's quite a bit of literature out there about depression before and after routine surgeries that shows that people undergoing a routine surgery are likely to experience no change in their depression or have a worsening of their depression after the procedure. So this was interesting. In looking at ketamine versus S-ketamine, a 2023 study comparing the efficacy and tolerability of IV ketamine versus S-ketamine found that the drugs are about equal in efficacy and side effects. And so S-ketamine is given by a nasal spray. It's quite a volume of liquid that needs to get into a person's nose for that versus doing the infusion. Ketamine is often more economical in overall treatment costs. And so far, we're still waiting to see what might evolve in terms of questions about bioavailability versus binding in these two different forms of ketamine. So some things to think about when discussing ketamine with patients or thinking about ketamine for a patient. The side effects of ketamine, we don't know what the long-term side effects of repeated infusions of ketamine will be. We will do it in some maintenance protocols as a way of trying to keep people alive with severe suicidality, but we just don't know what bad things could happen down the line. It can cause high blood pressure, bladder irritation, and genitourinary problems. Dissociation is probably one of the things that I see people discontinue ketamine over the most. So in particularly people with PTSD and other trauma histories, they get this kind of feeling of uncontrolled dissociation that's really, really uncomfortable and anxiety provoking. And I've had more than one patient stop doing treatment because that was intolerable for them. Can also cause nausea. Again, there's a tolerance with a potential for abuse and addiction associated with ketamine, and a potential to induce mania and psychosis. So right now, there are some studies about the use of ketamine in patients who have a history of psychotic depression, bipolar disorder, so on and so forth. In terms of S-ketamine with the FDA label, that would be an off-label use for bipolar depression right now. It seems like the risk of inducing a mania or psychosis is probably a little bit overblown, but the studies that we have right now are just very small in numbers. So we need to first identify the right patient for ketamine because there can be a lot of variability in diagnostic accuracy. A person who's going through a DSM-5 checklist of symptoms is oftentimes not going to catch some of the nuance of, depression as a symptom is not necessarily major depressive disorder, and the studies and the evidence is very specific to people with these disorders. So again, psychiatric symptoms can present across many conditions. A person with PTSD can have depressed mood as part of that. And that comorbidities are very common. So sometimes in even identifying treatment resistance and trying to find patients who would be good candidates for certain treatments, it's hard to sometimes sort out, is this an effect of the anxiety, the comorbid addiction, the personality disorder, things like that can make things kind of muddy. There can be inaccuracies in their treatment history. So trying to find out actual trials of medications that patients have had can sometimes be difficult. Electronic medical records are making that a little bit easier, but in order to establish that a person has in fact failed so many antidepressant trials, how long that took, if they had side effects, what were those, that can take some investigative work. And that can sometimes be a problem with insurance. So if a person's looking for S-ketamine, if they haven't failed a certain number of trials, they might not be able to get reimbursed for that treatment. In the case of TMS, that's something that we run into pretty frequently, even though TMS is recommended after one treatment failure of an antidepressant in the right candidate. Insurances still require that a person fails 3, 4, or more antidepressant trials, and that's documented before they can get the treatment. It's also important to set expectations. People who are coming in for the miracle cure, this is going to be the thing that fixes everything. You really need to be careful about, these are the things that this has the evidence to be helpful for. This is the effect that you can expect. This is how long it's going to last. But in many of our patients, there are going to be other things going on that need to be addressed in order for that patient to experience a holistic recovery. And we need to set the expectation that ketamine is not going to be the magic answer for a number of our patients. So some of the logistics of treatment with ketamine and S-ketamine. First is availability. So here in Fargo, we have 2 ketamine clinics that do IV infusions of ketamine, and those are cash practices. And we have, I believe right now, one, I don't know if there's others, but for sure one provider who is doing S-ketamine in their clinic. So that's in Fargo. Elsewhere, with the availability of behavioral health, that might not be something that can even be available to a patient. The need for transportation. So because they are experiencing dissociative effects and they're not anesthetic doses of ketamine, but they can cause dissociative and other adverse events. The person will need help with transportation for treatments. The cost, right now, last I knew, paying out of pocket for a ketamine infusion, IV infusion, was about $500 a treatment, which can be cost prohibitive to a number of folks. S-ketamine is several $1,000s. insurance, it does have a label for treatment for depression and suicidality, but some insurances do not reimburse adequately that people can even access that depending on what type of insurance they have. And then time commitment. So there is the need to go in, sit for an infusion. If you're getting S-ketamine through a nasal spray, there is a monitoring period for a couple of hours afterwards to monitor for adverse events. So it does disrupt a person's schedule. Some points about lack of regulation. Many of the clinics offering ketamine throughout the country do not involve a psychiatrist. And providers giving ketamine infusions may not have any psychiatric training. So when we're talking about the nuance of some of the diagnoses and setting expectations for patients and finding the right patients, that can be a concern. There's also a lot of variability in evidence-based treatment protocols. So if somebody is doing ketamine infusions in a clinic and it's a cash-only practice, they don't have to follow any particular protocols or any type of evidence-based things. So you can see a lot of variability in the dosing, the routes of administration. There's people who are compounding ketamine lozenges and giving those to people to take home in between treatments. Some are doing ketamine through IM injections, and there's no evidence for that. And that goes along with a lack of standardization in treatment guidelines and just some limited opportunities for training and education, as this is a newer treatment. So going forward, I see that expansion of ketamine and psychedelic-assisted treatments and psychotherapies are something that are going to be studied, and there are trials underway right now combining ketamine and other psychedelic substances with treatment protocols to help with PTSD, things like that. We're looking towards novel treatment mechanisms for rapidly treating severe and chronic mental illness and getting people into treatment earlier in order to reduce the chronicity and the occurrence of treatment resistance. We need to keep in mind that there is a significant psychosocial factor that plays into many of our psychiatric patients and will influence what treatment is available and what course is best for them. Psychiatric research does have problems with treatment study design. So in ketamine, placebo is one of those things that's really hard to come up with. There are significant novelty effects that come up. Hey, this is the newest and greatest thing that they're studying. I'm in this trial, which can cause people to have improvements. Clinical practice is appearing to outpace the evidence, at least as I'm seeing it in many communities. And sometimes we need to just do our best with what we have. And that can mean accepting that, this based on where I'm at and what patients I have, this might not be something that's accessible to them. It's helpful to not put your patient in a position of, well, yes, if we could just get this, ketamine treatment and things like that. That's usually not a helpful dialogue. If it's not accessible to them, then you need to set the example of moving forward with the things that you do have access to. The concept of psychiatric dialysis. So treatments and new protocols and new mechanisms of actions, they're always coming to light. And sometimes we need to just keep patients going until that treatment that's going to work for them comes about. When we're treating chronic illnesses, when we're treating chronic psychiatric illnesses, sometimes we are just doing things and trying different things and trying to support people through enough until they have that opportunity for recovery. And it's also important that we remember that hope and belief in patients is one of the most important things that we have. So both with our new treatments that are coming up and whether or not a patient has access to this, our role as a provider who is caring for this person and is willing to do whatever we can to help them within reason is frequently more therapeutically valuable than a lot of the other things that we do for our patients. I'm just going to take a minute here and see if there are questions. Where'd the chat box go? There we go. Oh, those were just links. Okay. Any questions?
I have a quick question, Dr. Shuck. Thank you for that. I know we have a case coming up here too, but So I saw that the one ketamine clinic in Fargo has a medical director who is an anesthesiologist and looks like a couple of CRNAs that probably work at the clinic. How does that work? Is that something you refer people to or others, or do they patients just go there and tell
Patients
them
do
their
not,
symptoms?
yeah. So patients do not need referrals, and in North Dakota, we CRNAs have independent practice, so they one of the clinics in Fargo is started and run by CRNAs, and the other one is an anesthesiologist. Um, and they do not have to um, they do not have to accept referrals. They oftentimes do partner with us as we're referring patients to them, and we're talking back and forth about the progress and kind of what we think our diagnostic impression is. Um, so when we make that referral, that suggestion to a patient, we tend to get some communication back and forth. When the patient goes and seeks those things on their own, sometimes we don't always hear back about what that plan is and how that's going.
Thank you.
Lisa, thanks much. This is really interesting. One of the questions I had, and I know that when we look at the difference between neuroplasticity with psychedelics, they're now being used, and with ketamine, with the psychedelics, there's a lot of emphasis on therapy during the session, on having someone move them through that. And even though these are different drugs and different neurotransmitter systems, is there any research on the use of those therapies while people are having ketamine infusions?
There are. I don't know of anything that's been published recently, but I do know that there are some studies that are in the works right now with using psychotherapy during ketamine infusions. I do know of clinics that do that as their practice. Some of these are a little bit more Wild West in what they do with ketamine, to where they feel that dissociation is a desirable effect of the ketamine, and that is what helps them with the therapy piece of things. And again, we see this a lot in PTSD, whether or not theoretically that's going to hold up, where sometimes that numbing and dissociation separation is counter therapeutic to PTSD treatment. More to come, but there are studies in the works right now. All right, question in the chat. How can clinicians balance the immediate benefits of ketamine with the potential risks for patients with a history of substance use disorder? I think a lot of it has to do with proximity to the substance use disorder. Certainly, when a person is closer to their history of substance use or are currently using, that's going to compound your diagnosis pretty significantly, to where I think it would be very difficult to consider that to be a good referral for somebody. People with more remote histories, who have maintained sobriety for some time and are still having severe and resistant symptoms, that might be an appropriate referral in that case, because we know that mental illness, undertreated and untreated mental illness, is a huge risk factor in relapse. So I would say that that's one of the big things, is proximity to their recovery. How stable and have they had some recovery time, and have you established the diagnosis independent of the effects of their substance use? Current policies of Medicaid and Medicare regarding coverage of ketamine and S-ketamine treatments for eligible patients. Um, so ketamine infusions are not covered by insurances. Ketamine is an old, cheap drug. They mix it into the IV, and for pennies, they can give ketamine infusions. So nobody is going to the FDA to get these infusions on label, so that insurances would then reimburse for them. So that is why the infusions are typically cash only practices. Medicare and Medicaid, they do reimburse for S-ketamine. The rate is so low that the one clinic that does S-ketamine in Fargo does not accept that insurance for that particular treatment. In terms of other commercial insurances, it varies a lot. And again, oftentimes there's a lot of treatment failure proof and finagling that you have to do with commercial insurances to get it to get it approved. Other questions? All right. So my case is that of a 32-year-old woman. Starting in adolescence, she was diagnosed with bipolar disorder, PTSD, and generalized anxiety disorder. And she has struggled with depressed mood on and off for much of her adolescent and adult life. Her PTSD was from a sexual assault that occurred while she was an adolescent. Um, and she was admitted to inpatient psychiatry for worsening depressed mood and suicidal ideation. So for the last 6 to 8 weeks, she has been feeling like she's a burden to her family. She's had very poor energy and motivation. Her sleep is very restless. She has a difficult time staying asleep and falling asleep. And that doesn't appear to be related so much to her PTSD nightmares. Those had been well controlled with prazosin for some time. She was experiencing significant weight loss in the last 8 weeks, and 15 pounds on this girl was significant to where she was underweight. She was a slender gal at baseline and had dropped below an 18.5 BMI. Her current medications included lithium 600 milligrams daily, which got her to a trough level of 0.8, venlafaxine 225 milligrams daily, prazosin 2 milligrams at bedtime for her nightmares, and mirtazapine 15 milligrams at bedtime. The mirtazapine had been added in the last month or so with little benefit. The lithium, venlafaxine, and prazosin regimen was something that she had been on for some time. About a year ago, she had undergone a course of ECT with a similar episode. The trouble is that she was doing this on an outpatient basis. She lived several hours away. Her husband worked in farming, so he had a very busy schedule during the time of year that this happened to occur. She did have family support that was able to help her some of the time, but she was struggling with some complications with the ECT. She was having very long seizures. She was on lithium throughout the course of that, which can make things difficult with a person's anesthesia as they're waking up from ECT. And so she was struggling with some of the effects of that. And it took many treatments, 24 treatment course for her to reach remission and to stay there. We were doing ECT 3 times a week. She started to get better, and then every time we'd start to taper off, things would get worse again. So we'd increase, and it took us a long time to taper her off of that. This current episode was precipitated by severe marital and financial stressors, and unfortunately, part of it had to do with some of the financial hits and stress that happened when she was ill about a year ago. She's married, but she is the person who cares for the 3 young children in the home. She is responsible for everything that happens in the household. And she and her husband are undergoing some significant stress. She does have good support from parents who do step up and help with the kids and help her with her appointments and her medical needs when they can. So any questions about this case starting off in terms of the patient's background or, oops. So when I'm looking at this case, some of the things that I'm thinking about, she had a response to ECT in the past, but it took a lot to get there, and it was a significant stressor in her life. And although she did get well, it took a long time and caused a lot of burden on the family. She's in the hospital right now. So in terms of the post-anesthesia monitoring, the frequency of treatments, the driving, the transportation, things like that aren't as much of a burden, but she still is away from home. And logistically, that is difficult for their family system. And she's also had some undesirable side effects of her ECT, including the prolonged seizures that required a lot of monitoring, some post-ictal confusion that happened as the result of the medications that she's on. She's also somebody that we know has been on many medications in the past. She's been undergoing treatment for her depressed mood for quite some time. One of the things that stands out to me is a previous diagnosis of bipolar disorder, because there is that concern that if you're considering some other antidepressant and alternative therapies for depression, that you could potentially destabilize somebody's mood if they are if they have a history of bipolar disorder. Um, so in trying to balance the needs to get her stabilized and get her out of the hospital, um, do so in a way that's going to actually help her reach remission, but also, be able to um, do so in a way that's going to be stable for a longer period of time. What do we do here? So she was a gal that I decided to do ketamine infusions on in the hospital. She'd not had ketamine in the past. Oh, one other thing, with her weight loss and the fact that she was underweight, just as an aside, our traditional antidepressants do not typically work when patients are very low weighted. Your body tends to prioritize the bodily functions that are necessary to keep your heart beating and breathing and things like that. So it's not uncommon for people's depression and anxiety to get worse and become more treatment responsive as they are losing weight. So that affects her in particular was probably becoming less effective as a result of her weight loss and underweight status. So we started doing the ketamine infusions with her, and she ended up getting a total of 3 infusions in the hospital. And she experienced a quite robust response and ended up discharging. She was my outpatient for some time, and I followed her, and she continued to have pretty significant psychosocial stressors. She had the feeling that her marriage was probably headed toward divorce, and was making a plan to get out of that house and get the kids out and make some major changes in her life. And when we looked back on things, we didn't make any changes to what she had been doing in terms of the medications that she was getting in the hospital. She was actually able to get off of the mirtazapine as she had some ongoing stability. But she was a patient who had definitely, had the understanding and the realization that her life situation was going to continue to cause her stress and cause her difficulties long term. So the expectation was that she needed to get to a place where she was functional, where she could eat, she could sleep, she wasn't having the suicidal thoughts as intensely as she was, so that she could care for her children. And that was a good choice in her case. She ended up doing quite well. One of the other things that was helpful in choosing ketamine over ECT in this case was that if there was going to be a potential divorce and moving forward with legal proceedings, custody of children, things like that, ECT can have cognitive side effects and short-term memory side effects when a person is undergoing ECT. So if a person is involved in any type of legal situation or anything like that, especially when custody of kids is involved, we want to be very careful about mental health not being used against a person, but also that she was cognitively in the best place that she could be to be making decisions during those transient times where her memory was not going to be as good as it would be post ECT. In terms of the bipolar diagnosis, that was something that I went back and did a lot of digging on before we started with the treatment. It turns out that her bipolar disorder diagnosis was given to her when she was quite young. She had a lot of irritability with her depression, but it was mostly based on the fact that she had difficult and hard to treat depression. So you'll sometimes hear people say, yes, if a person has treatment-resistant depression, you should consider that it's bipolar depression, and treat with a mood stabilizer, which can be helpful, but that diagnosis of bipolar disorder without meeting the criteria for a manic or a hypomanic episode ended up getting her in a place where she carried a diagnosis on her chart that could have potentially prevented her from getting the therapy that she needed, because at the time in my protocol, I was not doing ketamine on folks with a history of bipolar disorder. There's just not enough evidence out there, and the risks would be potentially high with that. So that also illustrates the importance of having a good diagnosis in the beginning, and again, picking the right patient for the right treatment. Let's see, I think there was a question in the chat. I can bring that up again. Has she attempted PTSD therapy? Yes. So she had been working with a therapist for quite some time, and she had done quite well when some of the abuse and other issues started coming up in the marriage again during this patch before they separated. She did have some recurrence of PTSD symptoms, but at the time, her symptoms were fairly well controlled. which is again important because it's my folks with PTSD and that dissociative side effect that tend to quit treatment and not tolerate that. Questions about the case?
Lisa, I think one of the points early on, just the reminders when we talk about medication trials, it's just always so important to talk, figure out, were they therapeutic trials? What was the dose? How long were they on? It doesn't necessarily mean you would go back to it, but sometimes we certainly see there are opportunities wasted when it just says in the record failed, or they were on this and they were like on 25 trazodone or something. So it's always just a good reminder that even though it's a bit of a pain to document those sorts of things well, it really does help not only the consultants but the patients. So.
Any other questions? You can feel free to unmute yourself or put in the chat.
Well, if you do think of anything, feel free to reach out by email. I'm lisa.shook@und.edu. So connect, and if you have questions or feedback, I'd appreciate it. Thank you all.
Thanks so much for the great presentation.